Good evening, ladies and gentlemen. Thank you, AstraZeneca, to invite me to talk on how to select BTKI for your CLL patient, the luxury to choose, but what to choose. I am Amar Lal, hematologist, oncologist in Tamam Hospital. Will take 20 minutes from you to show my talk of 6 points. Start from some eye-opener and challenges and solution in 2022. Then I will take you first line treatment based on the Eliminate and Elevate TN trial. Then we will discuss how common are BTKI side effects, trial data versus real world experience. Then I will take you in relapsed refractory CLL based on the Elevate RR, Ascent, and ACCL 208 data. And we will show you the advantage of BTKI second generation therapy in the CLL. And my question in final will be from you. How do you predict for the BCL2 inhibitor versus BTKI in 2022? So eye-opener question starts, which guideline you use to treat CLL? You use 4 guideline, but we in our hospital use NCCN guideline. So let's say what NCCN say my frontline therapy option for CLL. So you can see here preferred regimen in 60 plus or 60 minus. You have tons of option. This raises the question, how do we choose? This actually developed challenge one, which is the frontline therapy of my patient. Then I will go to CLL. CLL is relapsed refractory disease. This is challenge two. And the third challenge is developed high risk cytogenetics is poor outcome. And fourth challenge is frail patient, they have lower PFS. To solve these all 4 challenges, we have NCCN guideline. And over the 3 decades of progress, you have risk stratification based on the Rai and Bennett category. But now we are in era of the FISH and cytogenetics. Here you can see the T53 mutation and IGHV less than 2% mutation develop unfavorable. Similarly, if you see the FISH deletion 11q and 17p, they are also unfavorable. So based on this, you will choose any 4 of these options, but again the question arises, which option? So there are always pros and cons of everything in our life. Like ibrutinib, you have long-term data, but the problem is indefinite duration and off-target side effects, atrial fibrillation, bleeding. Acalabrutinib has resolved this issue of off-target therapies, but again long-term treatment is needed. Venetoclax has time-limited data, but the problem is shorter follow-up and the high-risk cytogenetics don't respond properly. So now the question is there. How do you predict BCL2 inhibitor and BTKI 2020? Which agent is stronger on the survival advantage on these? I open the guideline. So what is the new in NCCN guideline? Actually, NCCN guideline is now based on the blocks. They have 5 blocks: efficacy, safety, quality, consistency, and affordability. Higher the block filled, higher the better the treatment option. So based on this, I will go first efficacy, safety, and quality. Then we'll see, which is the better. So first I will go previously untreated, and then I will go previously treated patients. So first is the previously untreated. So first I will go the efficacy based on the resonant true, and then ECOG, then FLAT trial, then Eliminate trial, and finally Elevate TN trial, which was updated in EHA last year, 2021. So now, first thing is the first BTKI, which caused the paradigm shift in resonant 2, which was seen in older patients. They excluded 17p. It is the longest follow-up of the BTKI, which has shown the clear benefit. PFS has shown about 85% reduction in the death and disease progress. If you go for Eliminate trial, they actually here included 17p, but they ate also obinutuzumab here. But the thing is, PFS slightly went down about 70%, but it didn't translate the overall survival. Then we have third trial, Elevate TN trial. It is also for older patient. Here also 17p included. And here are also 3 options. One is the standard of care, chloromibicil and obinutuzumab. then there are two options. Either you can use monotherapy ecloperatinib, and third option is ecloperatinib plus obinutuzumab. And here you can see clear difference. The difference is you can see the PFS is goes from 25 to versus 87%. It means if you check the hazard ratio, if you combine together, it is 90% reduction in disease progress and death. If you combine Acala and obinutuzumab, even only acalabrutinib, it reduces the progress of disease about the 80%. So it is a huge difference. How it translates overall survival? It translates the 5% of benefit of overall survival as well. So this is how you have seen efficacy. Second thing, as I mentioned in NCCN, they have met safety. Safety is important. Common side effect BTK inhibitor, we know there are cardiovascular side effect, hematological side effect, muscular side effect, infection and GI side effect, and additional side effect also derma and cytopenia as well. So how you select BTK inhibitor based on these things? It is very outgoing. This slides you have seen in many presentations, all BTKI, Ebro, Acala, and Zeno, and new upcoming BTKI. There are off and on target tests. So these are the targets that we're showing here. Is there a difference in the side effect? If you go by this, the thing is, if you go by TEC and EGFR, so you can see the bleeding difference first, which is caused by the inhibition of BTK and TEC in platelets. You have seen in the resonance trial, it is somewhere between 44%, and Acala is about 34%, and grade 3 is only 3%. Thrombocytopenia is also, here is 17%, here is 2%. So if you go by diarrhea, which is possibly due to EGFR inhibition, the GI side, so this is somewhere in resonance 48% to 42%, in Acala 39%, in grade 3, 3%, and similar mechanism postulated by Reish and Arthresia. But the question is, it is seen in the trials. Yes, it is seen in the trial. You can go from blue to red. It is more seen in the red color, like here, infection, diarrhea, bleeding, and atrial fibrillation more in first generation. And second generation, you can say white to blue color, it is less. But question arises, is this cross-trial comparison of the two agents can be done to conclude which is safer? It is not. It is actually injustice. We cannot do it. So what is the option? Only solution is head-to-head comparison trial, randomized trial, which has shown in back-to-back in two meetings, ASCO 2021 North, then you go to West Europe meeting EHA in 2021. There are two meetings, and they have shown an Elevate RR trial, and they have shown, second generation was first generation, clearly benefit second generation, acalabrutinib, reduced about, so you can say 50% in arrhythmias, about 70% in hypertension, 40% in bleeding, and 40% in diarrhea, and 40% in arthritis, and which message was also endorsed by the Alpine trial. They have somehow shown same benefit. So now going to the efficacy, safety, now quality and evidence. You have to go, some things and meet, data versus the real world practice. What we have seen in the real world practice, if you go by first generation, there is dose interruption 50%, dose reduction 15%, and discontinuation of therapy is there. And if you see by the real world practice, first generation ibrutinib, the toxicity is seen about 23%, and progression 7%, death 9%, and 11%. So 50% patient discontinued because of this. But area of interest, as we know, to atrial fibrillation and bleeding. In the trial, it is shown 11 to 16%, but real world practice, it goes up to 20s. And similarly here in bleeding is 8, and it goes to the 10%. The important thing is you have mentioned here, like green means first year. In first year is more found in the hypertension and all these things. So now comparison of incidence of hypertension, ibrutinib treated patient, the predict frequency. If you see predict is like here red color, but in observed is very higher. So this is ibrutinib with the 44%, and non-ibrutinib is 3.4%. It is higher. So in selected cardiovascular side effect, if you go by these red colors, maroon colors are this is Acala, and this is all blue color is first generation ibrutinib. You can say the evidence base is different trials. They've shown somewhere between 3%. And here is 11% bleeding, but here you can say it's higher. It goes from 5 to 34% with the bleeding as well. Now, other select cardiovascular side effects also seen here in somewhere higher percentage, including the discontinuation and sudden death. And hypertension fibrillation, and if you go by real world, if you go the pool data with the collaborative, the thing is they have shown about grade 3% somewhere, and atrial fibrillation is just 1%. Now, you have seen the quality and consistency with the real world practice. Now we'll go to for final thing is relapse refractory and to comparison the different TKI. So in this, I will go first Elevate RR trial, which is going to shift up something treatment choice, then Ascent trial, then AC trial. So Elevate trial, which was just recently last ESCO was presented, and this is very huge trial. If you go by number of the patients, it is more than 500 patients. I think this is the first trial you can say novel to novel agent to in the same disease to check first generation with the second generation with the standard dose to see the primary endpoint is non-inferiority and secondary endpoint is actually the side effect which was creating problem, which drug should be chosen. So now they reached the primary endpoint. There is non-inferiority meet PFS. You can see there is no difference. The important thing is safety, which is important to select an adverse effect. There is 6% less adverse effect here in treatment-related treatment. It is about 8%, and also due to treatment discontinuation is also 6.6%. So which are those most important thing in the atrial fibrillation flutter, which cut down is almost 6%, and hypertension is 13.8%, and bleeding is 13%. It's a huge number. And even the retrospective data, they have showed non-treatment with the BTKI, they have shown also like this one. But the important thing will go back to Elevate RR. What is the benefit here? This blue is first generation, and this maroon is a collaborative second generation. You can say hazard ratio is 0.52, which means 50% reduction with the help of second generation. And hypertension, you can say here hazard ratio is 0.34, almost you can say 70% reduction of the hypertension side effect with the second generation. Bleeding event is also an important thing, which also for about 40% better with the second generation. Diarrhea is also 40% better. Arthritis is 40% better. So all these have shown huge difference with the second generation versus the first generation. So this is the summary of Elevate RR trial. That study compared the two BTK and the CLL. Primary endpoint, yes, they reach there is non-inferior and statistically significant lower rate of cardiovascular side effect you have seen, and the treatment discontinuation also lower in the new generation. So this was the seen first. Now I will go to another trial, which is also a very big trial based on the 300 patient Ascent trial. This was also published in the JCO 2020. The ACALA versus the standard of care of the treatment in those days. So this is open label trial, and you can see the efficacy first. The PFS here is actually based on the 17P, and here is the IGHV base. So here you can see below this all actually ACALA based ACALA with deletion and with 17 deletion. They have clear cut benefit. Hazard ratio you can say with deletion is about 0.13, almost you can say 87% reduction of disease progress, and similarly without is also 0.34, about 70% reduction. Similarly, IGHV mutation, this is which is important to choose chemo versus targeted therapy. They have also given the benefit. There is clear cut benefit. You can hazard ratio is 0.3 and 0.3, about 70% benefit if you choose. And this is also not only this one, the important thing is they translate the overall survival, that is about 7% increase with acalabrutinib as compared to the standard of care in those days. Now the side effect, as I mentioned before, there's a less side effect of atrial fibrillation, hemorrhage, and hypertension with the second generation, which we discussed already in the first trial. So 3-year follow-up Ascent trial supports the favorable efficacy and safety of acalabrutinib versus standard of care treatment and relapsed refractory CLL. acalabrutinib maintained acceptable tolerability profile with no new safety finding identified. The long-term follow-up, this data from 3-year follow-up ASCEND study supports the use of acalabrutinib in patients relapsed refractory, including patients with the high-risk features which I mentioned, 17p and IgG unmutated, which have shown clearly benefit about 70 to 90% benefit. So the last one is ACCL20 study. It's a very important study, though the number is in the small 60. But the important thing is the interest is here in this. The people who are intolerant to the first generation ibrutinib, they discontinue or they have some side effect. They were switched to the acalabrutinib 100 milligram BD to see what is their response. Very important. The response was about 78%. Even CR is about this one, and this is the PR is about 65%. Huge response. This is the median PFS, which was not reached as well, you can say. And important thing is, the first generation, when the atrial fibrillation was 16%, here was 2%. So you can see all the side effects decline when you go from first generation to side effect, and they tolerate it as well. So this is, again, encouraging that if a patient is not tolerating first generation and move to the second generation, they will tolerate well. So last 15-20 minutes, I tried my best to help you to select BTKI for your patient from the bunch of the luxury by opening eyes, going through the challenges to give you some solution for 2022. I have gone through the first line trial, especially Resonant 2, Eliminate and Elevate TN trial. We discuss 10 minutes about BTKI side effect from real world to trial data. And we have gone through the relapsed refractory trial, especially the Elevate RR trial and ACCL20 trial and ASCEND trial. And now you can say what is the advantage of second generation over the first generation, especially Elevate RR. You can see how much you can save the patient from the side effect. Even your side effect from the first generation, you can move from the ACCL20 base. So now, your turn is there. I ask you one question. How do you predict for BCL2 inhibitor versus BTKI in 2022? This is question for you. This is my 6th part of my presentation. This is closing question. You will go by first generation. You will go by second generation. You will go by BTKI plus venetoclax, and you will go also a combination as well, the Cephase one, suppose BTKI and plus, acalabrutinib, which is no side effects. So thank you very much. I am happy to answer you any questions. Thank you.